Started at 6:30.
Oh my God.
We still had difficulty.
Okay, so for that particular scenario, expectation-wise, this is for the therapist, the idea was that your patient was unconscious up to this point, and then as soon as you started any kind of vitals, they woke up. And so the expectation was the minute they wake up, you do a good history. They should have been complaining about one particular area, expose, palpate, try to determine what it is at this point, and then return back to your vitals and then finish off your head to toe. So that was the idea. I saw one group do C-spine stuff to try to rule that out. Is that a priority? It's not really a priority, but you could have done that as well. Okay. Just a couple of things to add, because I was watching the one group and they did a bleed. I wasn't sure if they did the actual squeeze part. A question came up yesterday because one student yesterday had the actual laminated form that they got from EMR. You guys all have that. And there's always confusion from year to year about the head to toe when you're on site versus the head to toe when you're in the actual ambulance. Again, just realize that when you wear different hats, EMR versus AT, you don't have an ambulance. Okay. In most trauma books, there is a head to toe, DCAP-LSITIC, in the primary. In other books, it's called the rapid trauma assessment as well. I call it bleed and squeeze. You can use whatever term you want to use for that head to toe in your primary, but the intention of that head to toe is to find anything that could cause that scenario to turn into a problem with your ABCs. We talked about this last week. What's one condition that you would only find by palpating that might contribute to problems with your breathing? Sorry? Flail chest, what's another one? Sucking chest wound. If you don't manage that until here, you've already wasted a bunch of time and their breathing could have stopped. And that's why we try to find it here. So your primary thing to look for in your primary survey head to toe is anything that might affect ABC. So that's why I always tell people do the cavities first, do the extremities last. Even down here, start with the head to toe, head, thorax, abdomen, pelvis, then do the extremities last. What I've seen on the OPs is as soon as they do the head and neck, some people will do the arms and then go to the chest. It's a small change. It's a picky change on my part, depending on how fast your arm assessment is, and then you get to the thorax, preferably go to the thorax. What could stall you checking out the thorax is if you find an arm fracture. What I've seen people do is they'll get all caught up in the arm fracture, check PMS, let's put a splint on, someone stabilized. Meanwhile, the person's bleeding out of their ribs. Okay? What's more important? The ribs.
So you just tell someone to stabilize to
Yeah. Okay. But again, make sure you do the body cavities first, the arms and legs last. I didn't see much to comment on. I thought from where I was standing, I think everyone relatively did a good job. Is there anything that you guys want to talk about? Any confusion? Do things differently? Okay, it was an appendicitis, and there was a medical appraisal.
So I was kind of like asking you went over exactly how we should have gone through it.
Yeah.
Would you just go over that?
Sure. The idea was primary survey, they were unconscious. So that doesn't change in what they should have done. As soon as they started doing the vitals, we told the patients to wake up. As soon as they wake up, history taking, because of the pain they're complaining of in a specific area is now focused, expose that area, palpate, and do any kind of assessment you need to do right away. So if it's a leg fracture, you go to the area and then you check PMS here, stabilize, and then move on. As soon as, for this particular scenario, it was the abdomen, you expose, you palpate, you think it's appendicitis, you do your sample, get all your history right away, and then go back to your vitals. And then once that's done, if you have time, head to toe. Okay. Now, is the head to toe in this particular case absolutely necessary? I would say it depends. If you think that they're in so much pain, the severity of the pain is so much, that this injury could be distracting, it's imperative you do a full head to toe. Okay. You guys have heard the term distracting injuries before? Okay, that's a confounding variable for C-spine as well. Okay. If it's not that bad, so it's 5 or 6 out of 10, then do you actually have to do head to toe? I would only do that if you have time to kill.
Can you like have fever and be in shock at the same time?
That's a good question. I think shock would override the fever, to be honest. But I'm not sure. That's a good question. Because for shock, it's pale, cool climate, whereas fever is
Still wear gloves.
What's that?
The cleaning guy. Are the gloves outside?
Again?
Totally just stole.
Twice.
Came in, looked at us, holding them, and then went.
These are mine.
He just gave it to us. He's like, what? That's it. Okay, anyhow. Any questions about that scenario?
Chase him down.
Okay, any questions about that scenario?
No.
I'll go chase him now. Okay, let's take a quick 5. Quick 5, we'll get them. Quick 5, we'll come back, we'll talk about houses, we'll do 2 more scenarios.
Okay.
Okay, 5 minutes.